All right. Thank you very much for the invitation. This is not my talk. Dr. Kumar Madasari wasn't able to make it, so Dr. Krishnan asked me to give this talk. He said, there's no freebies here, so how about if you take it? I told him, I'll do it as long as you provide me the slides. All righty, so here we go. There's no disclosures related to this talk. The objective is to discuss the management of ISR with potential thrombus. So what is the issue here? Well, there's a large population of patients with PAD that have extensive metal scaffold within the femoral popliteal compartment. And as you all know, the Achilles tendon in this compartment that we put metal scaffolds or stents is ISR. So let's start with a few clinical cases. This is a 68-year-old female, 2 prior revascularizations with spot stenting, presented with 1 to 3 weeks of acute pain and cool right lower extremity. Motor exam was intact. This is the angiogram that was done prior to the intervention, some disease in the ostium of the SFA, mild to moderate in the proximal section of the artery. However, in the distal SFA, you see an occluded stent. And you see below the knee, there's a very poor flow reconstituting the posterior tibialis artery. Now, there's different options on how to treat this patient. Or you cross and do POBA, or you cross POBA and reline with stents, or you cross to atherectomy followed by POBA, or you cross, do a PTA and finalize with drug-coated balloon, or you could cross to atherectomy and finish up with drug-coated balloon, or you cross, do thrombectomy and drug-coated balloon, or a combination of these last two if you have mixed plaques, such as intimal hyperplasia and thrombus. So the older approach is to cross the lesion, do plain old balloon angioplasty, and reline if needed. And if you're lucky, you have a good result. But if you don't, and you convert a claudican to a critical limb into an acute limb, you hate yourself for not considering another strategy. So over time, we learned that when you cross a lesion of the wire, it goes freely, and you identify that this is possibly a thrombus, or you have the advent of using intravascular imaging, and you realize that the patient has thrombus or clot. You place the patient on a perfusion protocol for 24, 48 hours, or whatever it may be, drip at TPA from 0.5 to 2 milligrams an hour, and bring him back the next day, reshoot it again. If it's clean, great. If it's not, you may extract some of the thrombus. If there's a large thrombus burden, then you continue lysis for the next 12 or 24 hours. So this is what they did in this case. They put a perfusion catheter at Craig McNamara. They perfused for 24 hours. And when they came back, most of the artery had been already cleaned out, except the posterior tibialis artery, which was then intervened with balloon angioplasty and stent, with very good result. As you see, there's straight line flow into the PT and into the foot. So they've mentioned already the data for ISR management. It's a little scattered, and I'll repeat some of the studies that have already been mentioned. 30 to 50% of stents have some sort of degree of instant restenosis. The Reline study randomized 100 patients to a PTFE cover stent versus POBA. Average length of ISR was 19 centimeters. Those randomized to PTFE cover stent had a 75% patency rate at 12 months versus 29% for plain old balloon angioplasty. And we had an 80% freedom of target lesion revascularization, favoring PTFE cover stent versus balloon angioplasty. Nicholas mentioned the Exit Star study as well, laser plus PTA versus PTA, 250 patients. At 6 months, the combined strategy had a freedom of TLR of 74% versus 52% with just balloon angioplasty, with pretty robust patency at 71% compared to 56% with PTA alone. And the Impact Global ISR cohort were 166 patients. Out of a little over 1,500 patients, the patency rate was of 89% at 12 months with paclitaxel covered balloon, and freedom of TLR of 93%, which is quite good. So ideally, what we would like to do is see inside of the artery and identify what's the contact within the ISR plaque. Because most of the times it's not only intimal hyperplasia, sometimes just clot, etc. So you see this lesion here. I can't be 100% convinced that this may not have been caused by a small dissection, or there may be some calcium that I'm not seeing, or there may be a very thin layer of thrombus, or this is just a plain old stenosis from atherosclerosis. However, if you use intravascular ultrasound, you're able to identify if there's any intimal dissection, or if there's calcium and thrombus, or there's ISR with or without thrombus. So they mentioned already several atherectomy devices that can be used successfully, lasers indicated for ISR. There's also atherothrombectomy catheters that do both thrombectomy and atherectomy, Rotarex and Jetstream, as well as we can also use directional atherectomy successfully. Again, some devices are primary atherectomy devices, other are thrombectomy, and there's others, as I mentioned, that have a combined approach. So this is a case that was also presented, male, 60 years, diabetes, coronary disease, hypertension, multiple myeloma, PAD was progressive claudication, and this patient had a difficulty walking with increasing claudication within the last weeks. Now, this case was already presented. I'm not sure if the slides are from Nicholas or the writer of this presentation, but we've already seen that this patient had a complete occlusion of the distal SFA with reconstitution distally, and you saw that the patient had reconstitution in the posterior tibialis artery, with an IVUS that showed that there was ISR and thrombus within that stent. Patient was treated, as Nicholas shown, was treated with laser atherothrombectomy with excellent results after a scoring balloon and a drug-coated balloon. So the question is, would you need filter in all of these cases? And if you see this filter, the answer would probably be yes. And most manufacturers would recommend some sort of embolic protection device, even though the data is fragmented and inconsistent. In the NAV6 during Jetstream, 2% of the patients that had Jetstream and had a filter had some sort of debris. However, those that did not have a filter had about 8% of embolization. The definitive LE study, those had used a spider embolic protection device with an adjunct directional atherectomy, showed debris in greater than 80% of the cases. Now, microemboli you may not think is important, only if you don't think that occluding a pedal vessel is not important. For me, it is. Now, depending on your experience, you could decide whether you want to use a filter or not. I have no way of identifying which of these lesions are going to embolize and which will not. So in my particular case, I use a filter at all times when I do atherectomy. As I mentioned before, the times that I have not, I've paid for it dearly. I show this another case. It's a 70-year-old patient with a FEMPOP stenting 18 months ago, present with a subacute worsening of left lower extremity pain. You see he had occluded SFA stents, a full metal jacket throughout the femoral popliteal compartment. They did a first pass with a penumbra, wire C down. Second pass, they pulled the wire back and then aspirated on their way back. This is the result prior to laser and drug-coated balloon. Now, If this is what you get when you do one of these procedures with atherectomy, you have to ask yourself, do you think that lysis alone or plain old balloon angioplasty is going to take care of it? The likelihood is not. This is likely going to shower down and close the distal vessels. Finally, we have another case. A 70-year-old patient was a fem-pop, some prior stenting over the last 23 months for lifestyle-limiting claudication, 2 weeks of worsening acute pain in a cool right lower extremity. As you see, the proximal portion of the SFA is okay, lumpy, bumpy, mild to moderate disease, but the distal SFA has an occluded stenting extending into the P2 segment. There's poor runoff reconstituting again in the posterior tibialis artery into the ankle. They went up and over. They advanced a wire with the support of a catheter, and it seemed to go rather smoothly, which would suggest that you're probably looking at a thrombus or some sort of clot formation. The patient was treated with penumbra, 2 passes. One was a 7 French bolt aspiration device and a 6 French device at the level of the popliteal. And this is the final result. Excellent flow in the posterior tibialis artery, on the peroneal artery. So what is my approach? Whenever I encounter a patient that has ISR, especially patients with a cover stent, I cross over, up and over with a 7 French sheath. I almost universally put a filter and try to aspirate as much as I can. And I may then follow this with extramural laser and then plain old balloon angioplasty or drug-coated balloon. If I need any other adjunctive therapy, then I may consider that as well. Thank you.